Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN Transition Program, and this PowerPoint voiceover is going to be on Chapter 15, which is Obsessive Compulsive and Related Disorders, or also known as OCD. This is actually found in your psych book, and it's on page 252 is where it actually starts. Again, I would like for you to do is read the chapter leisurely, in the sense that just really understanding what OCD means, that it really is truly an anxiety-driven disorder, and that people do certain things to help relieve that anxiety. So it's really a matter of trying to either break the habit or figure out what will work to make the OCD go away in order for the anxiety to go down. So it's kind of an interesting disease process or psychological disease. So anyways, let's see here. OCD is classified as an anxiety disorder, but with unique manifestations in the way patients attempt to decrease or control their anxiety. Obsessions are recurrent, persistent, intrusive, and unwanted thoughts, images, and impulses. Compulsions are ritualistic or repetitive behaviors that a person carries out continuously in an attempt to decrease anxiety. So again, this is an anxiety-driven disease process. Related compulsive disorders, there's self-soothing behaviors, which is excoriation, which is skin picking, onychophagia, which is nail biting, which I think all of us probably at some point in our life bit our nails, and it's just a matter of whether or not you grew out of it. I personally stopped biting my nails about 10 years ago, but it also took me going to a third world country to realize that I'm not able to stick my fingers in my mouth, or I'd probably get some horrible death, disease. But it was also the idea that patients or people who actually bite their nails are wanting their nails to be as perfect as possible, so they keep biting them until there's nothing left. Once I stopped biting them, they actually grew out and actually got them trimmed up and cleaned up. I stopped biting them. So that's probably the way I did it. I don't think it was necessarily anxiety driven, but I think it was just more of a habit. I never did the hair pulling thing. Let's see here. Reward-seeking behaviors. There's kleptomania, which is the compulsive stealing. They have oniomania, which is a compulsive buying. With compulsive buyers, these are people who feel good about themselves and feel better after they actually buy things. Don't necessarily need them, but it's the idea that they want it and they actually buy it and it makes them feel better. Hoarding, for me, from what I understand and realize with hoarders, it's more of they save every little thing because everything has some sort of emotional attachment. The anxiety is when you're trying to get rid of those things and they feel as if you're throwing away, whether it be their history or their attachment or some sort of memory. And then there's pyromania, which is fire setting. Pyromaniacs, I don't really know, but I'm assuming that these people get some sort of gratification from wanting to actually start fires or burning things down. So. Other related compulsive disorders, this is disorders of body appearance and function. They have body dysmorphic disorder, which is the preoccupation with slight or even imagined physical imperfection. When I was reading your book, I think that this even mentions that people who find a flaw focus on the flaw and then they actually correct it. They either still see the flaw or they now see a flaw with the fixed or the outcome of what was actually fixed. So they're never really truly happy with what has ever been done to be able to fix that issue. Body identity and integrity disorder. This is feeling alienated from a part of the body to the extent of seeking amputation of the identified body part. Again, this seems odd to me because I could imagine walking around thinking that my foot was not part of my body and wanting it to be removed. But I'm also, clinically, I'm diagnosed as being sane. So. Etiology of OCD and related disorders. Cognitive model. This is based on Aaron Beck's work with focus on cognitive behavioral therapy. Focuses on childhood and environmental experiences of growing up. And then they also have hereditary, which is complex network of several genes which may contribute to the genetic risk for OCD. I did actually read, took some notes. Let's see here. Let's see here. This is what I have as far as my own notes. So I've got obsessions as being recurrent and persistent, compulsions as being repetitive and ritualistic. Um, Examples of that would be checking rituals, like checking the front door, checking to make sure the burners are off, checking to make sure the lights are off. There's also counting, washing and scrubbing, praying and chanting, touching, rubbing, and tapping, and ordering, like putting things in actual specific orders. I actually wrote down the related disorders. I think that's all I had so far. So, anyways, I want to make sure that I was kind of up to date with the book in my notes and the PowerPoint at the same time. So, cultural considerations. Fairly universal internationally, other than how symptoms expressed or beliefs about the symptoms. Ethnic differences may also be found in the types of OCD symptoms or beliefs that people experience. Studies found that OCD was consistent across cultures in terms of diagnosis, but variances exist in symptom expression or belief about the symptoms. Highly religious individuals, both Christian and Muslim, were found to have a heightened sense of personal guilt. So basically, at this point, it's just like saying that regardless of what culture you live in or belong to or where you live in the entire world, OCD is OCD. So, is the following statement true or false? OCD can be manifested through many behaviors, all of which are repetitive and meaningless. The person understands that these rituals are unusual and he or she can prevent them by avoiding the source of the stress. The answer is going to be false. Although it is true that OCD is manifested through many behaviors and that the person is aware that the rituals are unusual, he or she feels forced to perform them in order to eliminate or alleviate anxiety or prevent terrible thoughts. OCD is chronic and extremely difficult to conquer. Treatment is long-term and therapy. Treatment is long-term therapy plus medication. Let's see here. OCD is diagnosed once thoughts or behaviors consume the person to the point where the thoughts or actions interfere with personal, social, and/or occupational functioning. So again, tapping your foot as a anxiety, relief is not a big deal. But when it gets to the point where you physically cannot move because of the fact that your foot is tapping, or if you can't do your job, or if it's actually starting to interfere with your life, then then you have to take it to a level to where you either need to get some help, whether it be therapies or medications. At some point, it's ruining your life or running it. The person realizes that the thoughts and behaviors are unreasonable, but he or she cannot stop and control them. I had a cousin who, when we were both younger, he had OCD. His was more of the hand washing and the scrubbing. He actually believed that everything he touched had the AIDS virus on it, and that, of course, we were 5, 6, 7, 8 years old, so he didn't really know. But he believed that everything that he touched had the AIDS virus on it, and he knew that if he got AIDS, he was going to die. So everything that he touched, he washed his hands, fanatically after touching or playing or doing anything with anything. I think that he eventually kind of grew out of it. It probably actually shifted from being that to his anxiety shifting to something else that was more OCD. But nevertheless, he actually outgrew that ritualistic behavior, and he no longer does that. So, but it took a while. It probably took him several years. Let's see here. The obsessive thoughts or compulsive behaviors help to decrease control anxiety. There's a great distress and shame caused by the thoughts and behaviors that cause the person to attempt to keep the thoughts or behaviors in a secret from others. So again, some of these people, as in my cousin, he actually knew that he washed his hands and scrubbed them, and he knew there was really ritualistic. He knew that we knew this, and he just didn't care. I mean, the anxiety was so high that this was more important than what people actually thought. So let's see here. Symptoms wax and wane with stress levels. Not really quite sure if I remember whether or not he washed and scrubbed more as anxiety and stress levels increased, but I just knew that he did it all the time. Onset of OCD after the age of 50 is extremely rare and should alert to a possible organic cause for the behavior. Common obsessive thoughts and themes. There's contamination, religious preoccupation or blasphemy, aggressive urges, there's doubting, there's accidental harm to others, and then there's also sexual. Common compulsions, there's checking rituals, counting rituals. I talked about the washing and the scrubbing, praying and chanting, touching, rubbing, and tapping, ordering, rearranging things, and then exhibiting rigid performance. So, patient family teaching, define OCD and assist in recognizing patient's symptoms, review importance of openly discussing obsessions, compulsions, and anxiety, emphasize that medication compliance is an important part of the OCD treatment, discuss behavioral techniques for managing anxiety and decreasing OCD symptoms, teach family to avoid giving advice, teach family to avoid trying to fix the problem, teach family to be patient with its own discomfort, and teach family to monitor its own anxiety level. Give family permission to take a break from the situation as needed. So I think what this is basically saying that, it's the person who has the OCD is not going to stop doing the rituals or the patterns just because that's for them a way or to deal with the anxiety. And sometimes that anxiety is so bad that what they're doing is more important, and maybe they believe it really will kill them if they don't do the ritual. So it's something that they need to do. For family patient teaching, it's a matter of getting people to understand what it is that the patient is doing in order to relieve the anxiety. So I believe that the patient can get help, whether it be through therapy or through medication, but it's kind of on their own terms with step-by-step processes in order to get that far. Family, again, when, like my cousin, he was, like I said, very young. I'm not quite sure if I remember seeing his family doing anything to help stop the pattern, but they may stop it in front of you, but they're just not going to stop doing it because all you have done to stop the pattern is increase their anxiety, and then they're just going to go off by themselves and do it anyways. So treatment. So combination of medications and therapies. Medications, the first line is SSRIs. The second line is SNRIs, and the treatment-resistant OCD is second-generation antipsychotropics, which is risperidone, quetiapine, and alazapine. Those medications, I believe, can be found on 254. They actually have the obsessive compulsive disorder. That's how it's diagnosed, so I think that's kind of important. So read through that. Excuse me. Doesn't say very specifically, I don't think. As I was flipping through this, I do like on page 260 the nursing interventions for OCD. They also have the 261, the client family education for OCD. For the client, teach about OCD, review the importance of talking openly about obsessive compulsions and anxiety, emphasize medication compliance is an important part of the treatment. Yes, we covered all that. So, all right. Other things, there's behavioral therapy, cognitive behavioral therapy, which is treatment focusing on examining the relationship between thoughts, feelings, and behaviors. There's exposure therapy, which is deliberately confronting the situation and stimuli that one usually tries to avoid. So the obsessive compulsive behavior is caused by the anxiety, but what's causing the anxiety in the patient? So I think once we figure out what's causing the anxiety and what they can do to overcome that anxiety based on that stressor, might actually just solve the whole entire problem itself. There's also response prevention, delay or avoid performing the ritual, learn to tolerate the thoughts and the anxiety. So if someone's, anxiety is thousands is going to burn down when they're not home because they left the burner on, of course they're constantly checking the burners. So I think that once the patient can actually realize that the house will not burn down because they did not leave the burner on, then the ritual will probably diminish on its own. But it's just a matter of getting them to either delay or avoid the performing the ritual and realizing that I didn't check the burner 10 times, so the house didn't burn down, so it must be, okay. So which of the following is considered a treatment option for patients experiencing OCD? There's avoidance therapy, there's response, which is reaction therapy, there's memory flooding, and exposure therapy. And the answer is going to be exposure therapy. So exposure therapy is used in OCD when a patient deliberately confronts the situation and or stimuli that he or she usually tries to avoid. The actual term for avoidance therapy is aversion therapy. It is used in treating fear, not OCD. There is no such thing as a response reaction therapy. Memory flooding is a technique used in post-traumatic stress disorder. So OCD in the nursing process application, the assessment. So Yale-Brown Obsessive Compulsive Scale, which is found in box 15-1. It's actually found on page 258. I think that's actually pretty good. You're also going to get a history. You're going to get a general appearance, motor behavioral. I think the general appearance is more or less making sure that they're, if they've haven't showered in a week and haven't shaved and haven't, they stink and haven't done any sort of hygiene, then whatever is causing the anxiety and whatever's causing the behaviors is what's actually disrupting their life. You're going to assess mood and affect. You're going to assess their thought process and the content. What is their thought process? Are they able to have a train of thought? What is the content behind their thought process? What is causing the anxiety? What is causing, by the time they actually come to you for help, I think that the anxiety has gotten to a point where they can't control it, even through the obsessive compulsive behaviors. You're also going to assess judgment and insight. You're going to assess self-concept. You're going to assess roles and relationships, psychological self-care considerations, find out sleeping problems, because a lot of psychological disorders do cause either people to sleep too much or not to be able to sleep at all. Possible nursing diagnosis for OCD is anxiety, ineffective coping. We have fatigue, situational low self-esteem, impaired skin integrity, risk for infection, risk for self-harm, risk-prone health behavior, and powerlessness. Again, OCD is more of an anxiety-driven disease process. So between the anxiety, I would probably also think risk for self-harm. Sometimes the anxiety gets to the point where the behavior becomes so powerful that that's not enough and possibly harm themselves in the process. OCD in the nursing process application, overcome identification, interventions such as therapeutic communication, relaxation techniques, behavioral techniques, daily routine completion, diary and a log. They also have patient family education, and then we also have the evaluation. So, is the following statement true or false? The best way to help a patient with OCD is to avoid talking about the obsessive compulsive behaviors, as the patient feels ashamed of the behaviors. And the answer is going to be false. Although a patient with OCD is typically ashamed and embarrassed by the behaviors, it is important to offer encouragement, support, and compassion, to be clear that you believe he or she can change, and to develop to develop and follow a written schedule with specified time and activities. In order to accomplish these tasks, you will need to talk with the patient about the behaviors. Self-awareness issues need to understand how and why OCD behaviors work. OCD is a chronic condition involving bizarre thoughts and behaviors. OCD treatment is dependent upon meds, daily structure, and long-term behavioral therapy, and avoid trying to fix the patient's problems. Well, that was 18 minutes, pretty short and sweet. Again, read the book, just kind of follow along and understand that, like I said, this is an anxiety-driven disease process, and it's probably something they're going to have either all their life, or they have to be able to figure out how they can use the tools to, get through it and to be able to be able to focus on other things and like I said, figure out what's going to work to get them through it. So anyways, I think that is pretty much about it. So if you have any questions, bring your questions to class. Thank you.